Quick introduction. My name is Lisa Karasik. I head up communications for Jewish Federation in the heart of New Jersey. And welcome everybody. We're going to have lots of opportunities to ask you how you're doing. And I know that while we're all distancing from each other, we're facing interesting challenges, and we're just delighted to have Dr. Nancy Gornish with us to answer our questions from the perspective of an infectious diseases doctor. And Nancy is on the staff and faculty at Hackensack Meridian Jersey Shore University Medical Center. And Jewish Federation is just so happy to welcome everybody, because even though we're distancing physically from each other, one of the hallmarks of Federation is an expression, Kol Yisrael Aravim Ze Bazeh, which means we're responsible for each other. And it's our very reason for being at Federation, because no one should ever be truly alone. And so we're just happy that we can keep the Jewish community connected and informed and supported. So please don't hesitate to reach out to us. Our phone number is 732-588-1800. Let us know how we can help. And be sure to stay connected at jewishlifeonline.org. So without further ado, Nancy Gornish MD, thank you for being with us. And I know that a lot of you submitted questions. So Dr. Nancy is going to just start with sort of a general intro and take some of the questions that were submitted. And time permitting, we'll open it up for just some discussion as well, or new questions that might come up.
Thank you.
Thank you.
Just give you a moment history of me. So I did my residency at Jersey Shore, and then I went on to Robert Wood Johnson to do my infectious disease. I've been practicing at Jersey Shore for about 28 years. And I started my career sort of at the AIDS epidemic. So I've been through a different kind of epidemic where we as physicians were learning what to do for our patients as the research was happening. So similar now that we're using a lot of the therapeutics and recommendations from our colleagues in China and Italy, sort of in real time. So I thought I would just do a quick summary of this particular virus. So in 2003, we actually had another coronavirus outbreak called SARS. Back then it was called COVID-1, and but it never really left the healthcare facility, and it wasn't as contagious, so we didn't see it outside of about 20 countries, but it never really came to the United States. So as you all know, this is COVID-2. It unfortunately has shown us to be much more contagious than the previous coronavirus. And unfortunately, as you've probably heard on television that the Chinese didn't sort of let on how contagious this was, because it didn't allow us to mitigate and control our own spread sort of early enough. So I guess the big question has been how it is transferred. So just without getting too molecular, viruses can be transferred droplet-wise and airborne-wise. And that determines what kind of mask we use, how far the infection goes from the patient. So we originally thought coronavirus or COVID was only droplet, which tells us that the virus particles are heavy. So as someone coughs or sneezes, these particles drop to the ground quickly. So at first it was not thought to be airborne at all. And we thought it was similar to influenza, which is more of a droplet. So in the hospital, we don't wear N95 masks for influenza because it's not airborne. So when we started isolating our patients, more out of concern than data, we did put them on airborne, and all of our nursing staff and doctors were wearing N95 masks. And those are primarily for airborne infections. We now know that this virus can be airborne, usually no longer than 3 hours, and that it doesn't travel very far because it is a little heavy. So therefore, they came up with a 6-foot distance. So that's why we tell everybody to be 6 feet apart, because if a patient sneezes or coughs, this virus should not travel more than 6 feet. And that's why we should all distance ourselves. So then we have the asymptomatic spreader. So these patients unfortunately have no symptoms yet can still spread it to us. And so that's why we are now recommending masks, even in the public, because we're concerned that these spreaders could inadvertently pass it to us. So a lot of people are questioning whether we should wear masks. These are actually more to protect the spreader from infecting other people versus the other way around. So the masks in public now are actually trying to control these people who are asymptomatic and don't even know that they're potentially contagious to other people. As far as the symptoms, it's similar to flu. So up to 88% of patients will develop a fever. It's usually high grade, like over 101 to 103, but it doesn't have to be. And we do know not everybody can get a fever. It's usually followed by a cough, usually dry, so you're not producing a lot of sputum or phlegm. And then the typical flu symptoms, body aches, tiredness, lack of appetite. We then learned that there can be sort of gastrointestinal symptoms, not just respiratory, and they're generally nausea and diarrhea. There have been some vomiting, but that's not that common. And then the most serious part of this is 7 to 10 days into the syndrome is where your 20% of patients could progress to very severe respiratory problems and breathing issues. And that's primarily the people that we're admitting to the hospital. And so that's sort of the overview of the clinical part of the infection. I thought maybe if you want, I can start turning to some of the questions, or if anyone has a question right now before I get to the submitted questions.
Hi, thank you. I'm just wondering about the masks, because I went online today and I can't find any masks. So I was wondering, can I still use like a scarf or a bandana, or is that just wasteful? I mean,
no, it's not wasteful. No, it's not wasteful. So any type of mouth and nose covering is sufficient when you're not taking care of people in the hospital. So again, it's, you're protecting yourself, but it's really for, the other person who's infected. So it's not going to stop everything, but if you're away from that person, like 6 feet away, it's just extra protection for you. So it can be a scarf. It can be it doesn't have to be anything medical. And it is very important to cover the nose and mouth, because the viral particles can enter both those. We see people walking around sometimes just covering the mouth. And for those of you who haven't worn masks, they can be very uncomfortable. They're not because they're tight, but it's just they're claustrophobic feeling. Some people, get uncomfortable. So, but you do want to cover both your nose and your mouth at the same time. Some people have sort of covered just the mouth. But just the scarf is sufficient for your grocery shopping and things that you might be doing.
Person has COVID-19 and recovers and has the antibodies, can they still transmit the disease or carry it to another person? And the second thing, I'd like to get a sense of what's going to happen when the social distancing stops and the curve starts to go down, and people, especially people at risk, go out when there's no social distancing anymore. What happens in those cases? Don't they have to continue to take the same precautions?
The answer to your first question is, once you have developed antibodies, you are not considered contagious and you cannot spread the virus anymore. The official recommendation for our positive infected people is that you must be symptom-free for a full 72 hours. That means no fever without Tylenol, no cough, all, completely symptom free, and at least 7 days from your first, say your first day of fever or your first day of symptoms. So 3 days. So most antibodies, there's two types. There's something called an IgM, which is an early antibody, and an IgG. So they are now starting to put out tests that can measure these antibodies. So the first one is the IgM, which starts to present usually early on, usually in the first week of illness. The IgG usually is made about 2 to 4 weeks after illness. So once you confer antibodies, you are not contagious. They are deeming people not contagious even without this information, because we don't have the antibody testing widespread yet. So no, you are not contagious with the antibodies. While we're on that subject, the question came, are you at risk of getting reinfected? So while you have antibodies, you are protected from getting reinfected. The issue is that coronavirus antibodies have been short-lived and they may not be lifetime, so that once that IgG antibody is no longer detectable, a person can be at risk again of getting reinfected. But I think during this particular outbreak, the person is probably protected for at least 6 months. And then your second question, ask me it again.
When the curve starts to go down and the
Oh, yeah. I think that New Jersey and New York are not going to be out of social distancing as fast as other locations that are not as heavily infected. I think that we are not, this is my personal opinion, that we are not going to be going back to exactly how we were in December and January, of 2019 and 2020. I don't think we can just go completely back to the way we were. I think there's going to be a time where we still have to be careful and distance. Colleagues and I have been talking about, restaurants. I think the tables are going to stay apart. I think we're going to be all a lot more cautious. I think handshaking may not be happening anymore. I think that we will continue to stay a bit apart. I think we could probably start seeing our families more, but I think in public places, I don't see us returning right back to our normal lifestyle prior to this. I think it's going to have to be a gradual return, and while the researchers follow this virus, because we know that these viruses do sort of go away and come back. We know we have a flu season every year, but it goes away for a few months. So I think we're going to rely on our researchers to follow this virus, and its trend to where it goes from here. I hope that answered your question.
Yes, thank you.
Okay. Subject of masks, and I'll turn it to gloves, because when I've gone to the store, I see a lot of people wearing masks and gloves. In the hospital, when we put gloves on for a patient prior to COVID, we wear those gloves for that one patient. We walk out of the room, we throw them out. So our concern is, and that's what we're doing now. Our concern is people out in public wearing gloves to the supermarket or other stores, and then traveling back to their car, taking their packages out, getting back in their car, going to their next stop and going to their next stop. And there's a lot of concern that people wearing gloves could inadvertently transfer something they picked up in one store to their car, to the next store, to the next store. So we're encouraging people, when you leave one store, is to remove those gloves. And if you have the opportunity to wash your hands afterwards, and if you're going to do a second errand, to put on a different pair of gloves. Because again, you could inadvertently pass the virus from your glove to the next place. So we don't want people wearing the same gloves all day long for multiple errands.
Go ahead.
If it's not passed through the skin, if that's not a vector, then what's the purpose of the glove if you're not touching your hands to your face?
Right. So I think I saw your question, so it might have been from you. Yeah. So I think the gloves are making, I think it's for people who are worried about touching a product in a store that somebody else has touched, because you're counting on everybody to be, you know, to not be passing it around. I think the gloves are, most of us and my colleagues feel that people are less likely to get COVID from their Amazon box and their cereal box from the supermarket and all of that. So, but people subconsciously touch their face. So, you know, you get an itch, you scratch your face, you get something in your eye, you know, so it's not your cheek, and it's your eyes, your nose, and your mouth. So this viruses actually are not living things that can live on their own. So this virus has to get inside something to survive. After that, you know, we learned that it can survive for about a day or two on plastic, but after that, it dies. So it has to get somewhere in your body to survive and start multiplying. And that's your mucous membranes. So if you accidentally scratch your cheek, that's certainly not risky. It's more about, you know, touching your mouth, the nose, and the eyes. So your nose itches, you rub it. And so that's the concern. So, and that's why. So I agree. I mean, if you're really not touching your face, you're right. It does not penetrate your hands. And that's why hand washing is so important. So while we're on hand washing, this virus has a lipid layer around it that's protective. The reason for the 20-second hand wash is to create enough foam and soap to degrade that, and then the virus dies. So when you're washing your hands, you really do want to do sort of a very kind of friction-y kind of rubbing to get as much foam and soap bubble out of it, because that's actually what's killing the virus. A lot of hand washing will be more helpful than the gloves, probably, yes.
I have a question, Nancy. Does it matter if you're washing your hands with cold water, warm water, hot water?
So this cold water does nothing. So you really kind of want to wash your hands with as warm a temperature as you can without, you know, burning yourself. So the magic degrees is 80 degrees. So I know one of the other questions is washing clothes in cold water. It is not advised to use cold water at this time, because it really does not kill the virus. So you want to wash all your clothes on warm, and, you know, few things can tolerate hot water. I mean, when we look up the clothes washing recommendations, they do say still read the label. We don't want people destroying their clothes and trying to wash them in, you know, water, but cold water, unfortunately, is not as preferred by any means. Yeah.
Current recommendations for outpatient treatment.
Yeah. I'm going to back up by telling you that the data on hydroxychloroquine comes out of an observational, not even a study really, from Italy of 6 patients that they did nasal testing 6 days in a row after starting hydroxychloroquine. And on the 6th day, some of the patients had no more virus. They know from a test tube that hydroxychloroquine does have activity against coronavirus, but we have to make sure what happens in a test tube also happens in the human body. And that's the whole, you know, where we go with our trials. So hydroxychloroquine, although getting a lot of TV press, has very little medical data behind it. So as an outpatient treatment, we are not starting hydroxychloroquine. We're not recommending it because there's not any data to say that we should. And that we are reserving hydroxychloroquine for hospitalized patients. Outpatient treatment is basically symptomatic treatment. So fevers, there was some early studies saying anti-inflammatories like ibuprofen and products like Aleve and Advil were harmful. That data might be reversing, but for now, we recommend Tylenol for the fever and body aches. And then just what you do when you have the flu, but no antibiotics, no hydroxychloroquine for our outpatient population.
How communicable is it outdoors? And a related question was, can I visit with my neighbor in our backyard?
So actually, outpatient is probably less communicable because the natural wind can sort of take that brief aerosolized virus away from people. So outside is probably safer than inside because the virus doesn't sort of have hang time as long. As far as meeting, because we're getting this question a lot, you know, if we stay 6 feet away, you know, can we go visit a neighbor? My mother's been begging me to come down and visit me if she promises to stay 6 feet away from me. Right now, we are trying to mitigate this infection. And this upcoming week is supposed to be our worst week. So we are still recommending really strict sheltering and not visiting neighbors, even if you're six feet apart. Yeah. We really want to be ultra strict because we're, you know, we want to get this virus under control as far as numbers. So, and this is what we think, you know, we think it's 6 feet, you know, but we don't want to be wrong. And then that person 10 feet out, you know, still gets infected. So I'm still recommending sheltering. I mean, and, you know, my colleagues as well. People are really wanting to get together for the holidays. I actually heard Trump want to open up churches for Easter. I think this year just, it can't happen, you know.
I shop in the supermarket. Do I have to worry? It says something about lettuce, like, could the virus be living on fresh produce in the produce department? If you pick up the lettuce from the shelf, could somebody else's virus be on that lettuce?
Yeah.
To buy and eat raw vegetables?
So I've noticed in my own supermarket, things are getting more packaged, you know, like things that used to be just fresh and open are now in plastic, but, you know, we don't know who put it in the plastic. The answer is yes, it could be briefly on there. And that's why when you take it home, they recommend. I've actually seen a video where somebody washes produce with soap and water. I've never washed my produce with soap and water, but that you can use the lettuce, you just wash it.
Are you familiar with the veggie washes that you can buy in the market? The sprays of like fruit and vegetable wash, do those do anything?
I guess the honest answer is I don't know if they're sufficient. I don't know if they're sufficient.
Safe? Would it be safer to cook your vegetables?
So I also do travel advice as part of my practice. And we have a rule of thumb, if you can't boil it or peel it, don't eat it. So yes, absolutely, cooking is best. We know this virus does not tolerate heat, let alone boiling. So anything over 80 degrees. So cooked food is always safest. Dry food in a box is safer than, you know, when I give advice to my travelers going to countries where, you know, it's not as safe, I do recommend no raw salads. And we're not really doing that now for COVID. I think that's not as necessary. That's more of a fecal contamination. But fruits with a rind or a peel are always safer because you're not eating what anybody's hands have ever touched. So like an orange, a grapefruit, a mango, a melon. So you're eating the fruit inside that nobody's hands ever touched, or nobody sneezed on your orange or coughed on your orange. So those fruits are probably more safe in general.
It says something about a doctor who practices and lives in New York at a clinic with confirmed cases, but no contact. Should that doctor come to a health center in New Jersey?
Yeah, I remember that question. So early in this pandemic, we discussed as part of our infection control role at Jersey Shore, what to do with a nurse, a doctor, a resident, or a respiratory therapist who gets exposed. Because if we put all of our staff out for 14 days, which is the recommended quarantine based on incubation time to symptoms, we'd have no staff. So what we've done is anyone who's had a possible exposure, we have them self-monitor. we had, well, prior to mandatory masking at Jersey Shore, we had them wear a mask and monitor for fever. So I think if the healthcare worker who works in New York, who clearly could have had an exposure, as long as they're masked and monitoring, we would allow them to practice.
To handle increased blood pressure. And I'm not sure if this question is about the medical aspects of blood pressure or the emotional aspects.
Right. Yeah, I'm not sure who asked that question and what the question is getting at. So I will answer it. So I know a lot of people have blood pressure monitors at home for people who have a history of blood pressure, hypertension. And many of our patients do check their blood pressure on their own. If a person finds that their blood pressure is running high, or they went to a pharmacy where you can get your blood pressure checked, many and most of my colleagues in the primary care world are doing telemedicine. So because we've tried to protect our patients and not bring them into like my own practice, we're trying to do as much telemedicine as possible, which is basically similar to this. We do have a video visit. Unfortunately, we can't take your blood pressure for you, but we can have a discussion about what your medications are, and if something needs, a dose needs to be elevated or a different medicine needs to be added, that can be done. So I would say if a person, someone who's dealing with high blood pressure probably would touch base with their primary care physician.
Why is there a recommendation to take your shoes off when you come in the house?
I mean, we as healthcare providers are doing that because we're walking into known COVID rooms. And if we approach a bed close, those temporary airborne particles could fall down to our shoes. And then we don't want to track it, from where we go. As far as the public, I'd say it's for the same reason. If somebody was in that grocery aisle before you, sneezed, and the particle fell to the ground and you stepped on it, I haven't seen how long it stays. Well, actually, leather has been shown to be better because you can wipe it off because it's the smooth product. The porous fabrics, I'm told, are harder, like a sneaker, were not like a canvas sneaker. So like leather shoes are easier to wipe down, but I think it's on them, I'd say low chance that you've stepped on a viral particle and don't want it tracking into your home. So
I think you need a test. What's the best way to get a test?
That's a great question. There are a couple of urgent centers that are doing outpatient testing. I know the one directly across the street from Jersey Shore has been doing testing for a couple of weeks. There was one in Eatontown, I think it's called Family Urgent Center on Route 35. It's been doing testing. We know the PNC Bank, or the Art Center is offering testing. Those are the three sites I know about that are actively testing. Primary care physicians have not brought the test into their office yet. I think some of them are thinking about bringing the test, the 5-minute test in when it's available, and then meeting the person in the parking lot and, taking the swab from the parking lot. We're trying to avoid clustering people in our waiting rooms. So those are the three sites that I know about that are actively doing testing. We ask that patients not come to our emergency room. We, of course, are testing, but we really need to keep our ER doctors for, our sicker patients.
Can anybody go to one of those sites and ask for a test, or do you need a specific prescription?
To my knowledge, you do not need a prescription. I know a lot of people, my own friends and people who had symptoms just went. I do not believe that you need a prescription. No. And I know that insurance companies have waived all co-pays and any fees for the testing. So there should be no concern about getting a big bill for it.
Are they testing only symptomatic people or everybody that wants to be tested?
Yeah.
Oh.
I mean, we would love to test everybody. It was just conservation of tests. Mm-hmm. So we were, well, not we, but those test sites were only testing symptomatic patients. I think what I've done with my own patients who are symptomatic but couldn't get a test, I think, unfortunately, we're sort of treating everybody like it's probable that it's COVID if you have classic symptoms, fever, dry cough, flu-like symptoms. And we are recommending what we would do if somebody was positive, because unfortunately, our test has a up to 23% false negative, which of course, so if you have a person who's symptomatic and their test is negative, it could be that we tested too early because you need a certain amount of virus, or no test is 100% sensitive. So we keep that in the back of our minds, like in the hospital, if a test comes back negative, but we strongly suspect infection, we're not discontinuing their isolation. And as far as repeat testing, for people are saying like test of cure, it's back to a volume thing, till they get more tests out. I think eventually everybody will be tested, but it's going to go to a blood test more like the antibody testing to see like the real epidemiology of this infection.
It's a follow-up on the symptomatic, the asymptomatic carrier.
Yeah.
Could a person be asymptomatic and be a carrier forever without ever becoming symptomatic?
How long do you stay?
Generally, I would say no. You're not a carrier forever. Your own, it will eventually clear out of you, and you will no longer be contagious. The duration of that, I don't think has actually been worked out yet, because, well, that was another problem because we're not testing these people. But, if someone's, so that's why it's important to that's why we do want to test lots of people, because we want to try to find these asymptomatic shedders and keep them out of, the public. So I think we're going to get there as more and more tests roll out. We're just trying to save them for our symptomatic patients at this point.
You could be negative today and positive tomorrow. So, the testing at what point in time?
Right. Yeah. So we've actually, in the early part of the testing, we were having plenty of tests. It's just the turnaround time for the results were too long. So, I've waited up to 9 days for a test result. Now, Jersey Shore has its in-house test. We have the results the same day. So that has greatly improved. But what happened is patients got admitted and tested. And because it was taking so long, we actually re-swabbed them. So it could be like 5 or 6 days later because we had been waiting so long, and now we had a better test. So we did the test again. We've had about 3 discordant tests, meaning the first one came back negative, the second one came back positive. So we've seen that happen, not often, but we've seen it happen. Because a lot of it's like your asymptomatic shedder, they have very low level of virus, even though they're still very contagious. So their test could be a false negative. So there's a lot of different things that could be happening with the testing and the shedding. But that's what we got to use so far. So I'd say the majority of the people that are symptomatic have positive tests, so that if you feel fine, it kind of doesn't, you don't really need a test.
What's your view on when a vaccine will be available?
So a vaccine I know has already been started, the trials. So when you do clinical trials, you do phase 1 trials, which the first thing is to make sure that the vaccine is safe. And you have to do it in a certain amount of people to make sure, different level of the antigen to see which one produces the best antibody. I lost my train of thought.
So you were talking about phases 1 and 2.
Oh, yeah. So when you make a vaccine, we still have to do it safely. So you have to, 1, you make sure it's safe, your vaccine. 2, then you do a dose escalation. So you have to figure out which vaccine dose is going to give you the protection you're looking for. And then you do phase 3, which is you mass vaccinate. So I'd say I'm hearing about a year to a year and a half from now. There are certain things in science that it can be rushed, but the last thing you want to do is put out an unsafe vaccine, because that's what happened with the Lyme vaccine. They pushed it out, and then they later found out it caused a lot of reactive arthritis. So you really want to be, that's why we don't have a Lyme vaccine. So we really want to make sure that it's a safe vaccine. And speaking of that, I know the public is frustrated that we don't have a cure and the test took a while and all of this, but I just want to give sort of a timeline of my own experience. So HIV virus the virus was identified in 1983 to 84. The test came out in 85. The first drug that ever was released in 1987, and the drug that turned around the life for those patients was released in 1996. So the fact that we're only 3 months in, I think science has done a lot in a really short period of time, so I think, so as far as finding a cure and, I'll let you know that there's a lot of trials going on. I'm part of an monoclonal antibody trial at Jersey Shore, Hackensack, all of our hospitals. They're looking at nitrous oxide to help oxygenate these patients. There's lots of trials going on trying to get at what, medication could work for these people. We've had some positive results at Jersey Shore. We have 5 people that came off ventilators. We've discharged hundreds of patients. So we hear about the top 20%, unfortunately, the sickest. But under that, the 80% that are mild to moderate and even hospitalized, but getting better and going home. So I always want to give some positive information for these people, for our patients.
Here's another question about airplane travel. So the vent on the airplane spread the disease or
right.
stop it?
So there was certainly concern about laminar flow in airplanes because it's recycled. Cancer is much of a problem as the person coughing or sneezing, close by you. And I also, at least from the most that I've read, that, we see a lot of airline death getting this infection towards people on those planes all day long. They didn't have a higher incidence as far as I know.
I just had a question on the social distancing. You spoke a little bit before, and that when some of the restrictions are released, you believe it would be a gradual process of slowly relaxing things. Can you speak at all? And this may be really hard because there's so much it might look like, your best estimates.
Most common question, even in the hospital. I'm really listening to the same people you're listening to on television. So I'm waiting to see what the case indexes go up in the next 1 to 2 weeks. Once we see that new case decline, and we get over that apex that they keep talking about, we've still got the whole other side of that bell-shaped curve to come down onto. So I think I really don't know. I mean, I've tried to get this answer, but I don't even think Dr. Fauci knows. I think he's just following the cases like, we're waiting to hear from him. But I don't see, I'd say we're probably looking at somewhat of a mitigation into the summer. And it doesn't mean we're going to be like this in the summer, but unfortunately New York and New Jersey just have so many cases. And most of us believe that New Jersey's gotten hit hard because so many of our commuters to New York City, many people work in New York City. And that's why Bergen County and Essex County have such high rates. And we have our own population that take the boat to the city or, commute to the city, because I think New York City really was likely because they have Kennedy and international flying, and we have Newark, and, that's where it all sort of clustered, and then it just spread out from there. So, but I mean, most of us think it's going to go into the summer, but not meaning like how we are now. But I think we're going to have to be cautious through the summer, at least. And then Dr. Fauci's talking about a little mini, you know, one in September, like not as bad. Like he's seems to be watching whether this virus sort of returns in the fall.
Mhm. Thank you.
So, but speaking of that though, I don't know if any of you are familiar with the term herd immunity. So the reason why, you know, influenza isn't as contagious, but, you know, I've been vaccinated for 28 years. So many people in the United States have antibodies to influenza each year. And the reason why so many people are getting sick is that none of us have any immunity to this particular strain of coronavirus. And so we are all so susceptible because of that. And our communities, nobody does either. So everybody is vulnerable, and that's contributing to it. So next year, we'll have all the people that did get exposed hopefully be somewhat protective, and so we won't have such large volume of people at risk.
I have a friend who says to me, vitamin C, vitamin D, and zinc, to take those things preventatively. What's your opinion about that?
There actually was a recent meta-analysis. So lots of people are publishing about vitamin C, and the point of vitamin C is that it acidifies your bloodstream and is supposed to interfere with the viral attachment in your lungs. So we are actually giving IV vitamin C to our patients. It's based on an Italian physician that was giving huge doses of vitamin C. We never gave the doses he was giving, but this meta-analysis meta-analysis just a pooled look at lots of people's experience, and at least what they could see, the people that benefited most was our patients on ventilators, and that the people who took it, you know, who are hospitalized or outpatients didn't see as much a difference. We were adding zinc also. There was some paper suggesting that zinc helped the hydroxychloroquine and the Zithromax together. So that's where all of that came from. But we really don't have hardcore data on that. It's all, everybody's trying everything, and, you know, but we don't, I can't say, I'd say it probably couldn't hurt. You got to watch how much vitamin C you take, but you know, if you're not taking mega dosing, it might help and won't hurt.
I had one other question regarding takeout food. Takeout food, like wiping down packages, should food be reheated? Any thoughts about that?
Most of us are suggesting that you take the package that your takeout food comes in, like the bag or whatever, and leave that bag in the garage and throw it out, and take the food, the literal food, out of whatever the container. We're back to the who touched what. So I don't think anyone touched the actual food, but it's more about what it comes in. So, you know, leaving all of the containers, you know, in the garage, throw it out, and scooping out the food, you know, with your own utensils, and not, you know, without touching the outside of whatever it came in. I mean, I really think these are very low risk things, as far as, I mean, versus wiping the bag down. Like if you just don't bring it into your kitchen, it's probably a safer way than trying to wipe down these bags, you know, so. And a lot of people say, like, when you go to the store, like the supermarket, and you don't need, like, it's not a perishable item, you know, the virus doesn't live for more than 24 hours on cardboard or plastic, a little bit longer. So if you don't need to bring the food in, leave it outside in your garage, and for a couple days, if you don't need to bring it into your home. And by that point, the virus has died because it can't survive after that. Like I went to Target the other day and bought a bunch of things. None of it was perishable. And I literally just left it in my garage for a day, you know, and never brought it into my house. I mean, the bags. Yeah.
Going to the comment about the seasonal possibility.
Yeah.
Is there anything out there about, like, we're in Florida, is there anything that they find anything about temperature and humidity that may affect this?
Well, they thought that humidity and heat was like will decrease the virus, and so we in New Jersey were hoping, as we entered our warmer months, that it would also take care of the virus. But we know that this virus is outbreaks in warm countries, and so we don't know. But we know warmth is not a good thing for this virus. So whether it's going to give you less cases, I don't know. But we definitely know that it survives better in the cool and cold weather, which is kind of contrary to what most people think. You figure it would freeze and it would be done with it, but unfortunately that's not what happens. So because I mean, like, they had outbreaks in Singapore, which is quite warm. So that's what we were all hoping too, that this warmer spring would bring a decrease in virus. So we'll have to wait and see.
Dr. Gornish, I had a question for you. I was just wondering, I read two different versions about the age of the population that's more at risk. They were calling elderly population over 60, and then they sort of changed it to over 65. Do you have any thoughts on that?
Well, actually, in our protocols now from Mass General, anyone over 55 is considered at risk, which is like getting lower and lower. I think it's partly about your age. Well, let's talk about that. So, you can be a very healthy 65-year-old, and you can be a very unhealthy 35 to 40-year-old. So we know that anyone with underlying lung disease is at risk. Is not as robust at 65 as it is at 40, and but the majority but I think when we're talking about real age risk, it's real people 80s and above. I mean, we unfortunately have a fair amount of younger patients in my hospital, 40s, 50s. So hard to say, but the older person, just their immune system just isn't as robust. So, but I think it matters the other part of you, whether you're 60 and have cardiac disease, if you have COPD or emphysema, you're not going to do potentially as well as the healthier 65-year-old. Yeah.
I think that we're just coming up on our time, in fact, a little bit over time, but does anybody have any burning last questions before we wrap up? Well, I just want to thank everybody for tuning in tonight, and I especially want to thank Dr. Nancy Gornish for giving up your time like this. What a great way to connect us and to just keep everybody informed. And I want to invite everybody on tonight's call to join us tomorrow night. Dr. Kerry Weiss, PhD. Kerry, you can wave to everybody. Will be with us for part 2 of the series Coping with COVID Stress, and that's tomorrow night at 7. Check your Zoom invitation online from Federation for that as well. And remember, call Federation, contact us. Our website dedicated to coronavirus is called jewishlifeonline.org. All kinds of resources there to connect you to Jewish life, Passover, synagogues, just entertainment, things to keep you busy and informed and always learning. And if you or someone you know needs help, please don't hesitate to let us know at Federation. That's what we're there for. So thank you again, everybody. Stay well, stay home, and stay in touch.
Thank you.